المشاركين اللي هم دول هيبقوا مشاركين معانا على طول من الأول أثناء المحاضرة كمان؟
من الأول دلوقتي.
تمام.
And the other attendees, they can vote in the chat. They can say option 1, option 2, option 3 on the chat, or differential diagnosis, or whatever you are requesting for that, Prof. Mu'taz.
Thank you.
We are live on Facebook now, and we are going to start in few seconds.
Dr. Tahan is with us?
Yes, he is, yeah. He's muted, yeah.
Yes.
Okay, ازاي حضرتك دكتور طحان؟
I'm so pleased today to start the third module, which is a little bit much more specialized than the other modules. And we're starting today. It is an honor to start the pediatric anesthesia tonight in the presence of 3 eminent speakers and 2 eminent and top moderator. We'll start with the microphone is going to Prof. Samir Ansari. The first time since we started this course on Sunday, not to be a lecture, but he's honoring us today by his presence to be a moderator of this session with Professor Manal Gohari. Prof. Samir, all for you. Thank you.
Thank you, Professor. Good evening. Good evening, my dear colleagues. Good evening, my dear attendees. Really, today we are going to enjoy a pediatric night. Especially, we have 3 professional stars in pediatric anesthesia sharing us their experience in 3 hot topics in that field. And as you know, this field is unique in its it is a critical branch which need special attention and special experience and special talent because of its unique physiology, unique characters, you need a unique special physiology, anatomy, and even in drug doses. We have to be oriented with its pharmacokinetic, pharmacodynamics, which differ largely from that used in adult. Pediatric anesthesia, as we know, carry special risk in morbidity and mortality, more than, of course, the adult anesthesia. Today, really, I am going to be a moderator, and actually, I like to present, and I like presentations, and even I like to attend the presentation. But also, I like to be a moderator, especially if I am going to introduce such famous and professional speakers and guest speaker. Like today, we have actually 3, as I said, 3 famous stars specialized in pediatric anesthesia, sharing us their long and extended experience in pediatric anesthesia. And please, my dear attendees, please help me now to welcome and introduce the prestigious and talent and professional, and also my dear colleague, Professor Dr. Hany Elzahaby, Chairman of Anesthesia and Intensive Care and Pain Management department at our dear and lovely university, Ain Shams Hospitals. Welcome, my dear colleague, Professor Dr. Hany. Mike with you now.
Thank you, Dr. Samir. It's my honor to be with you and my honor to hear these nice words about me. Thanks, Dr. Saad Mahdi, for letting me in this marvelous course, which is growing day by day. I'll start my talk today about basics of neonatal anesthesia, and I'll take the words of Dr. Ansari, who said that the great physiological and pharmacological differences or changes are there for these young patients, and they need continuous knowledge, continuous practice and skills added to an adequate monitoring and equipments to have a good outcome. we all know that the neonates are, we call them from day 0 to 29, whether full term when they reach 37 weeks, or preterm when they are less than that. And the post-conceptual age is the gestational age add to it the chronological age. Anesthetic considerations usually comes from being a neonate, and most of it comes from being a neonate. We call it age-specific considerations, and of course the type of surgery. If we take system by system and see what happened in it and how does it affect our practice, we start with the CNS, and today we all know that neonates feel pain, and most of the pain components are there by 30 weeks of gestation, starting from the peripheral receptors down to the spinal cords, ascending tract, and cerebral modulation. However, the ascending pathway is not complete. Neurotransmitters are not there before 48 weeks of gestation. What does it mean that the descending pathway, the inhibitory pathway that modulates pain, that will result in greater intensity of pain for a longer time, hyperinnervation of the areas next to the injured tissues, secondary hyperalgesia, and of course a 30%, at least 30% reduction in pain threshold with the next noxious stimulation. All these would have short-term consequences and long-term consequences on the nervous system of the neonate. They also have fragile cerebral blood vessels, which render them liable or prone for intraventricular hemorrhage in case of stress. Their spinal cord definitely extends at a lower level, and it's easy to get with tap when doing a crude epidural. We'll come to it later in this talk. And of course, the volume of CSF per kg is higher, and the spinal surface area are larger in units. That means that when doing spinal anesthesia, we need more doses of local anesthetics. When it comes to the respiratory system, we all know that they have higher oxygen consumption, higher respiratory rate, the minute ventilation is higher. But when they are apneic, with this high oxygen consumption, so desaturation occurs more rapidly. Their lung compliance is less, and high interchest compliance is high. So by the end of apnea, they tend to get atelectasis. So whenever you intubate a neonate, the first thing is to recruit this segmental atelectasis that happens during apnea. Their diaphragm gets easily fatigued, and they cannot increase their work. So again, they get easily fatigued. Their breathing, which is we call it periodic breathing, normal periodic breathing of the neonate, is accentuated by the anesthetics, opioids, and make them render for post-operative apnea. We all know that the breathing circuit that most frequently used is the modified ISTPs. So let's see what will happen with this respiratory feature. We use the modified ISTPs because it's light, it's low resistance, no valves in it, the space is low, compression volume is low, gases goes in and out fast, compliance, the compliance of the circuit is low, and of course we can feel the compliance of the lungs and chest wall. However, we cannot add, most of the gases are dry, very low humidity, and it needs a learning curve to properly use it to the desired volume and pressure. And of course, it's difficult to scavenge. The back may get obstructed and unnoticed. So this is the other type of circuit that we use when controlling ventilation, which is a circuit system. Well, this is a 15 millimeter diameter. When using these two circuits, we have to keep in mind two concepts: the bed space concept, which of the circuit, for example, and the resistance of the circuit, which comes from hoses, valves, and filters. If the unit breathes spontaneously in this circuit, the dead space may approach the tidal volume of the unit. You can imagine if we add to the spontaneous breathing one of these with a dead space of 34 up to 50 mils. So you cannot leave a unit breathing spontaneously in this circuit. And as a general rule, as we will see, that we cannot leave the unit breathing spontaneously for a long time because they get exhausted, especially when they are intubated and with a tube with high resistance, a lot of work of breathing. We cannot, if we add a filter to a spontaneous breathing, this is completely wrong. And even if they breathe spontaneously with through a laryngeal mask, although the resistance is low, but the dead space is high. Anatomically, they have a large ox. Of course, this is not an unit. This is a large ox. We have large ox which keep the head flexed forwards over the neck. So when you intubate them, you need a shoulder blade. You need this is the headrest and shoulder blade. That tries to keep to align this trachea to the sternal end. Nasal turbinates are not there, so they breathe easily through the nose, and they suffer a lot when nasal obstruction. The floor of the mouth is compressible, so frequently if you press on the floor of the mouth from outside, then the obstruction of the oral airway occurs. The tongue is large and will again easily obstruct oral airway. And of course, we know that if the larynx is high, and you have difficulty in aligning the visual axis, the three axes that we know. That's why in most of the case, we need external laryngeal manipulation to get a good view. The glottis is shaped, thin, and you cannot easily take it up, lift it up with the straight blades, which is commonly used in units. The vocal cords are slightly angled anteriorly, so most of the tubes come and hit the anterior wall of the larynx. So you need to tilt the tube to the left or decrease make a little bit of flex. Most of the you have to examine the lateral view of the mandible to see if there is micrognathia is there, which is a very important and common indicator of difficult intubation of the trachea. Signs of airway obstructions, we all know that it includes a stridor, prolonged inspiration, some voice changes, crying is changes, rocking movement of the chest, abdomen, and of course, when they use accessory muscles, you get tracheal tug, flaring nostril, and retraction of the intercostals. They tend to get postoperative apnea in up to 44 weeks in term units and up to 60 weeks in preterm units. And the central and the apnea is commonly a mixed apnea, both central and obstructive type. Postoperative apnea is exacerbated by many factors, but we have anemia is the most important factor that predisposes to postoperative apnea. Other factors include hypothermia, hypoglycemia, hypercalemia, narcotics, and we treated by raising the hematocrit, increasing oxygen, giving caffeine, maybe naloxone. But when we give this we don't send them home, and as they are safe, no, we keep on monitoring them for at least 12 hours of apnea-free period. When we come to the cardiovascular consideration related to the age, of course, they have high cardiac output, which is mainly dependent on the heart rate. Their fetal hemoglobin has high affinity for oxygen. Their contractility is dependent on extracellular calcium. This is very important because if calcium is low, then it's difficult to get normal blood pressure. Hypovolemia, or they have a predominant parasympathetic tone, so they don't get much tachycardia when they are light anesthesia, under light anesthesia or hypovolemic. Frequently, PDA do not close if there is hypercarbia or hypoxia after birth, and which gives high pressure in the pulmonary artery, making a shunt, a right to left shunt from the pulmonary artery to the aorta. When the pulmonary vascular resistance goes down later on, then, and this is not closed, then the flow will be reversed. In patients with patent ductus arteriosus, using the right arm saturation is recommended. They lose heat by 4 ways. The most important is by radiation, which accounts to about 60%. Second is by convection. Okay, so it is important to keep the room temperature high, to wrap, to do cotton wraps around the limbs, and of course keeping air warming mattress, which is the most effective air warming way in OR. The renal function, we have less glomerular filtration rate. We cannot retain sodium from being excreted in urine, and of course, when giving drugs, they have a large extracellular fluid, and together with decreased renal excretion. So the initial dose may be increased for many drugs, and but the intervals are usually longer. Their fluid requirements goes up through the first 5 days to be 115 mg/kg, and the electrolytes here. This is very important because frequently at the beginning of practicing pediatric anesthesia, many patients were cancelled for having potassium level of 6, and residents during residence would think that this is high and needs some correction, but this is normal ratio for potassium. They also have higher levels of calcium, especially in the first day, and this is in day 28. So at 6.2 or 6.3, we go to surgery without any problem. Of course, we may consider not giving succinate choline. When it comes to glucose homeostasis, we know the default is that all neonates need glucose infusion per kg per minute, about 5 to 8 milligrams per kg per minute. Their egoglycemic range is a range between 50 to 90. That means 40 should be treated, 110 should reduce the infusion rate of glucose. Of course, the lower limit is higher if the mother is diabetic and the neonate is the first 2 or 3 days. Hypoglycemia is common for if we are critically ill, if they fast for a long time. If you suddenly stop the TPM coming from the NICU. We have to know that most of the signs of hypoglycemia are blunted and non-specific, and we have to measure regularly the random blood sugar during operation. Is it then justified to use only glucose solution during operations? Of course not. We need to give the maintenance of glucose or half the maintenance of glucose because of stress, and then give the rest of the fluid as balanced salt solutions. They commonly have reflux, they commonly have icterus. Their hepatic drug metabolism is maybe affected, especially when their intra-abdominal pressure is high. The lowest acceptable hematocrit is higher than those of adults. If you accept like 25 or 30 in adults, the lowest acceptable hematocrit is 35. Their coagulation profile is almost nothing peculiar in it. So the fasting saturation, we all know that breast milk, 3 to 4 hours, we stop it. We keep giving clear fluids now up to 1 hour, and probably Dr. Mumtaz will say up to 0 hours. If they have clear fluid, they tell you they have clear fluid now, then by the time they come, you just can induce anesthesia. In case of emergency and in case of full stomach, then you need to decompress the stomach in different positions. So you fix your nail with the tube, try to do gentle aspiration, supine, and then to the right side, turn to the right side, turn to the left side, and repeat the aspiration. Pre-medication is debatable. Atropine is maybe given. The lowest dose is 100 mics. Whatever the body weight of the neonate, some people do not prefer to give. Of course, if there is pain, so the best pre-medication is morphine. Standard monitoring are added: ECG, esophageal stethoscope or pericardial stethoscope, blood pressure, temperature probes, whether lower esophageal or nasopharyngeal or rectal. Pulse oximeter definitely, but I have to elaborate that if you have a hypoxic unit, do not keep looking at the oxygen saturation, because the pulse oximeter takes about 10 seconds to average the reading. So you have to look at the chest expansion. End-tidal carbon side is crucial, definitely, but sometimes you get difficulty in getting good tracing of the end-tidal carbon dioxide, especially if you have a small endotracheal tube with a continuous leak around it. If the leak is large, then you will get that. This is definitely less than the actual end-tidal carbon dioxide. If you appeal to this, then it will go down even more. So this is a point where you measure end-tidal carbon dioxide. If you have this shape, then probably it's less than the normal, the real life. How long we pre-oxygenate neonates? That's since 1998. They said 60 seconds or 1 minute of 6 liters is enough to give you about like more than 1 minute of before they desaturate. Some people would prefer to get the end-tidal oxygen concentration above 80%, but believe me, it's difficult to achieve what you want. It's difficult to do real pre-oxygenation in units, and most of the time you need to do gentle manual ventilation to units before you intubate them, because otherwise you will get you try to intubate very early with the risk of regurgitation. Most of us will go for inhalation induction, because even if I have a needle, if I have an IV in place, because they gradually get loose their airway, there is no pain from propofol. Definitely, if you have a short procedure, then they will be better than induction, and maybe the parental presence during induction will help in that. If you have IV access and they are hemodynamically stable, then you may go for propofol, or if they are unstable, you may go for ketamine. If there is no IV access or the airway is compromised and you want to go for single inhalation, it's fine, 6%. By the end of when they are deep, when there's breathing slows and there's end-tidal carbon dioxide starts to increase, that means they are in deep level now for intubation. Very common now to give a hybrid technique at this stage and give 40 milligrams per kg. Gives you apnea for intubation, but they cough it. Can we do a rapid sequence induction in units? But less classic rapid sequence induction that is in our mind for adults is not suitable for units, because they easily get is hypoxic during the during apnea, and while they are not really deep enough, so again you may get start early intubation, and which may predispose to regurgitation. So actually there is no cricoid pressure in neonates in real life. You can do it because you will disturb everything. You cannot put your 2 fingers exactly on the cricoid pressure. Again, neonates must be gently ventilated between induction and intubation. The gold standard is to intubate neonates, whether for long procedure, intermediate time, or even for short procedures. Some would allow them for a very short, brief cases like circumcision to have a face mask with assisted breathing or a laryngeal mask in place. But remember that size 1 is commonly misplaced, and you frequently, if you keep on manually ventilating them, you may inflate the stomach. Succinylcholine, although the black box warning on the label is in the box itself, but if you need succinylcholine, if it is indicated for example, difficult intubation case, then you can give it without hesitation. Non-depolarizers, same dose as in adults, but we frequently give a single dose, like operation which stays for an hour, and we give the intubating dose, then probably we will not give another dose of nociceptive. Endotracheal intubation, gold standard, oral or nasal. Nasal if we are going to put the patient on prone position or even lateral position, or if we have a limited head access like in maxillofacial, then a nasal intubation may be a solution. The leak pressure should be less than 25, and in most of the cases we intubate with non-profit tubes because first of all it puts less pressure on the mucosa. You can put a larger tube, one size larger, but if you have poor lung compliance, then you may put a cuff tube. Frequently we put the micro-cuff tube if you have it. If you don't have, then the other the regular one will be okay, but you have to measure the cuff pressure and make sure that it's not tightly inflated. Gold standard again, after intubation, as we said, the atelectasis, commonly segmental atelectasis, commonly occur. So we need to recruit the lungs after intubation, immediately after intubation, and then to put them in feet that will prevent more atelectasis. This is a paraglossus technique, which you go from the far right side. So you don't you go direct to the base, to the right side of the base of the tongue, directly to the epiglottis. Just take it with you, and you can intubate in this position. Here is these 2 types. This is a micro-cuff tube, which they replaced the Murphy eye with this, so that the tube, the cuff is more distal. That is more anatomical because here is the narrowest part, probably is here, which may give, when using this micro-cuff tube, then probably post-intubation group would be less. But the size should be, is frequently be one size less than if you are going to put 3.5 non-cuff, then with the micro-cuff, then you put size 3. Pressure volume control or manual, which is frequently used, definitely. If you want to use a circle system with them on controlled ventilation, then classic teaching is the pressure control is the first choice because it avoids the barotrauma and compensates for leaks. What happened is that we go for the PIP, the peak inspirative pressure. We set the highest pressure that we want. For example, starting by 10 or 12. And check what is the expired volume. How this pressure with the current compliance of the chest wall and the lung and the surface, everything will give an expired, because if you are giving pressure control, you have to look for the volume. If you are if you are giving volume control, you have to look for the pressure. Then after checking this target, our tidal volume, usually we go for a protective lung strategy. The upper limit is like 6 mL. I personally go for 6 to start with, and then so I increase the pressure until I get 6 mL per kg. And then after that, I go up, I manipulate the respiratory rate to the desired in the tidal carbon dioxide and add it. What factors that affect the tidal volume in pressure control? The compliance, and here we have to bear in mind that the hand surgeon, the surgeon's hand itself, will decrease the compliance, and if the assistant retracts vigorously, then you will probably get nothing, no tidal volume. So you have to keep watching the expired tidal volume yourself, or use a pressure control volume guaranteed. This is a very useful. The other two factors are the inspiratory pressure, which if you increase it, then you get more tidal volume, and the inspiratory time difference. What is the disadvantage of pressure control is if the tube is kinky, for example, it will not allow. Disadvantage of volume control that we occasionally may use in case of decreased lung compliance or thoracic surgery or whatever. Then, because the disadvantage is that they do not compensate for leaks. And the phase flow, if you increase the phase flow, then the tidal volume increase goes up. If you decrease it, it will decrease. And of course, you lose volume through the circuit compliance. So if you adjust for example, if you put 50 mils, then you may lose 20 of them in the circuit. Of course, maintenance, I don't think anybody is using Halothane now. Occasionally, in some cases of difficult intubation, I still use Halothane for more time of laryngoscopy. Narcotics for fentanyl or morphine. The difference is, although morphine has longer duration that stay for like 8 or 9 hours, but the half-life of fentanyl is variable, extremely variable. It may be half an hour, maybe 7 or 8 hours. It depends on the high intra-abdominal pressure. So we usually avoid short procedures, and we revert to a regional block. Narcotics, again, they have low rate of clearance, high volume distribution, prolonged life. Their plasma concentration after bolus dose of narcotics is high. We can give narcotics easily to a patient who will be ventilated in the ICU, but we tend to stay away if we are planning to extubate and recover the patient. When it comes to regional blocks, the CSF volume per kg are higher. You see here it's almost 15 ml per kg. It's like 1.5 ml in adults. So this means that they, together with a leak around the spinal nerve, we have to give higher doses of glucoacids for spinal in minutes. Their turnover, CSF turnover rates are high, so the spinal will stay half an hour, 40 minutes maximum, unless you add it enough. Their globular fat is less dense, and you can easily thread a catheter caudally up to higher levels. So traditionally, we give spinal doses. You ask assistant to hold the neonate for you in a sitting position and use a separate needle. You just break the skin and by a separate needle to avoid inclusion dermoid, and then we give 0.1 ml per kg of bupivacaine 0.5%, with an insulin syringe. This is higher dose than in others. High spinal levels are not present with hypotension. It's usually apnea and desaturation. Epidural doses here where we reduce the dose of local anesthetic. So instead of giving the ceiling, our ceiling of order anesthesia, instead of 1 ml per kg bupropion for older children, we make it like 0.7 ml per kg once of 0.25%. Volume replacement is important because hemorrhage and blood loss and it accounts for like 9% of cardiac arrest in all. So it is very important to know or to diagnose, to assess the hydration state. Here, this one is always, when I ask what are the signs of dehydration, they go for sunken eyes, depressed fontanelle. This is extremely severe form of dehydration. But mild dehydration, which is common, you get only urine output less than usual. You need to weigh the swabs before it dries, and most of the intraoperative blood loss is replaced by balanced salt solution. And of course, this is the equation for maximal allowed blood loss. Emergence, I tend to reverse all muscle relaxants whenever whatever the time given since the last dose, and I depend on 2 main features: moving all limbs and giving facial grimacing. This is ensure awake intubation. So when you take the patient from deep stage through the light stage into the awake stage, and do not extubate into the light and the stage of light anesthesia, you probably are getting less complications to extubate awake. And the just plan usually is usually planned preoperatively with a regional block of infiltration, paracetamol. If his patient is going to ICU, then we can give morphine. We'll go through how many minutes? I think still maybe 5 minutes more. Okay. We get some cases. This is encephalocele, for example. Encephalocele has problems of that they tend to get when repair these meninges, they get a shunt. So usually they fix a shunt first, and during intubation we try to avoid damage to this one, blood loss, hypothermia, and even latex allergy is common. Second case is tracheal fistula. Just a concept that I want to elaborate. This is a common type. Okay, so the fistula is low. It's just above the cranium, maybe a centimeter above the cranium. So your aim is not to ventilate through the fistula, because if your tube is high, then you probably will get intubated. You inflate the stomach, and your surgeon will ask the surgeon to change their decision and go for gastrostomy during operation. This is a case that will indicate, for me, will indicate a spinal anesthesia, which is a neonate staying for long in ICU. And after passing through ventilation and intraventricular hemorrhage, multiple bronchopulmonary dysplasia, multiple medications, now their parents are looking for an inguinal hernia repair, and this is, for me, an indication for sole spinal anesthesia without sedation, because if you get sedation, then you can still get apnea. I will share very short 2 videos for the last case. This is neonate with, you can see, huge, rapidly growing a mass that is here in the frontal, coming from the frontal bone, and another mass on the right side of the neck. Okay. I'll leave you with this video. Actually, that's a nightmare for for me, for myself. And here I'm putting some xylofene gel on the right paraglossal area with my little finger. And then now I went with my little finger melting the epiglottis and the upper part of the larynx with a calculated 2p size lidocaine gel, which probably gives 10 together 10 milligrams of lidocaine. And then using the CMAC, pediatric CMAC for intubation. This is real time, no editing. Sorry, because the screen is tilted, but yeah, I anesthetized the right paraglossal base of the tongue, and then with my finger, as I said, I went to the epiglottis, making its upper and lower surface, and then we give another half cc of 2% lidocaine that I will spray. Here you go. This is the lidocaine 2%. Of course, there are other ways of doing this. I mean, by inducing inhalation anesthesia, nasopharyngeal way, but I mean, this is a safe option for me, and I successfully intubated that patient. And this here, the patient is intubated and surgery, and this we did the first part of surgery. And thank you very much. Thank you.
Thank you, Dr. Hany. Really attractive and amazing lectures. Highly beneficial for anyone who wants or interested to work in pediatric anesthesia. We have some questions here, Dr. Hany. The first one from Carlos Munir. He asked about, is propofol used before 1 year? Is propofol?
Yeah, the answer, the answer, it's a common question. And the answer is off-label use is extremely common, using propofol during even infancy and neonatal.
Second question from Muniz Abu Zdera. Do you have a reference for no cricoid pressure? If you have reference, please, you can write for him. The other questions from Muhammad Hashnam. Yes?
I cannot hear the question. I didn't call the question. Can you say the question again, please?
Do you have a reference for no cricoid pressure?
For no cricoid pressure?
For no
well,
pressure.
It's there is no cricoid pressure in units. If people try to do cricoid pressure, and then frequently they get distorted anatomy, and then they just ask the assistant to leave the cricoid, to let it out and intubate the patient. Because
he interested just to know the reference, Dr. He wants the reference.
I can send it on this. Yes.
Third question from Muhammad Hashim for induction. What you prefer for induction for pediatric?
Okay. It depends on many factors. First, how familiar you are in doing, for example, inhalation, induction and intubation. I frequently do use inhalation induction because most of the pediatric procedures are relatively short, and I need to exhibit them at the end. Of course, you can exhibit them when giving propofol, but the recovery time is long. I give inhalation anesthesia, sevoflurane, and if I can ventilate the neonate easily, then I give a dose of muscle relaxant, which make life easy for me. I just ventilate. It works. The onset is very fast. If you give even atracurium, in 20 seconds, it works. You can intubate the patient. So my preference is that inhalation induction, easy ventilation, muscle relaxant, and external laryngeal manipulation. The concept, why? Because the nightmare of anesthesiologists is to have an inhalation induction and a trial of intubation early, which is difficult. And then the patient goes into spasm and they cannot intubate and they desaturate. And this is the worst scenario. So I consider giving muscle relaxant and ventilating the neonate as de-arming the patient. Of course, if you give propofol after sevoflurane, you may get closer results, but I'm not fond of
it. Other questions from Mohammed Muqbil. Fentanyl can be used in small doses?
Yes, yes, definitely. For even, I mean, 1 to 2 mics per kg is enough, but you have to watch the recovery of, or the signs of that the fentanyl is wearing off. Because if you give on time, on basis of time, you may every half an hour you give fentanyl, then probably you will have longer time for extubation at the end of surgery.
From Mohammed Muqbil, also intraoperative pain management. Intraoperative pain management. I think
yes.
You need direction.
A lot of, yeah, it's a long one, but the concept is we give light general anesthesia combined with a regional block. This is the best if you can give both. For example, lower abdominal surgery, even up to umbilical hernia in infants. Single shot of epidural will help you to do that. If that's very common. Local infiltration of wounds for thoracotomy, for example, you can thread a catheter through the epidural space and measure the how many centimeters to the dermatome of the incision. Leave it there with no X-ray, nothing. No, you just assume it's in place and start giving epidural. But the patient should go to an NICU after that.
From Jumana Baj, she asked about is it safe to use Sugamedics in infant? Is it safe?
I have no experience using it. I have no experience in using it. I use the Hoffman degradation products of depolarizer muscle relaxant. Maybe my colleagues, Dr. Mu'taz, may comment on this.
Again, Dr. Hany, what was that again? Yeah.
Do you have experience in using Sugamedics and
Sugamedics and infant?
Oh yeah. We do use it, obviously, particularly in difficult intubation, but not generally. No.
Please.
4 milligram per kilo to reverse, but mainly in emergency, not as. Hello.
Yes, with you. Hearing you, Dr. Mu'taz.
Yeah, that's fine.
Not in routine use.
Some colleagues, I know some colleagues use it in routine use, but generally it's a very minority. And in our hospital, we don't use it in routine use, in routine reversal. We only use it in emergency. Yeah, emergency, i.e., you've used rocuronium and then you've got a difficult intubation. You won't wake the child up, so you give it as in the emergency situations.
Yes.
There's some, yeah.
So long you have a good experience in Sugamedics, Dr. Mu'taz.
Yes, I'm sorry, any more questions?
I wanted to ask you if there is any recolorization after using Sugamedics. I must say, in children,
we don't use it a lot. We don't have a huge experience in sigmoids in children and infants.
Yeah.
In adults, we've not seen recolorization, but in children, we don't have that experience to be able to comment on that.
Okay. Thank you.